Hi, my name is Aubrey Jones, and today we are going to be talking about heart failure very quickly. This will be a brief presentation, fairly succinct in regards to what types of medications you guys will want to select in this patient population. So first, just to define heart failure, it is a structural or functional impairment that really just results in the inability of the heart to pump blood at a rate sufficient to meet the metabolic demands of the body. The one definition that I want you to be familiar with throughout this presentation, because it's referred to in regards to how we classify heart failure, is the ejection fraction, which is the fraction of blood that is pumped out of the left ventricle with each heartbeat. Risk factors for heart failure include pretty much what you see in most older patients, so hypertension, diabetes, history of atherosclerotic disease, so a history of an MI or stroke, metabolic syndrome, lung disease, and the list goes on. So like I said, I wanted you guys to be familiar with that definition of ejection fraction because that's how we classify our heart failure. So we have preserved heart failure, which is HFpEF is the abbreviation. It's a problem with the filling. This is also known as diastolic dysfunction, and it results in an inadequate relaxation and loss of elasticity. To define this type of heart failure, the EF must be greater than 50%, and it is more common in elderly women and African Americans. The second type of heart failure is heart failure with reduced ejection fraction, abbreviated as HFrEF, and this is a problem with pumping. It's also known as systolic dysfunction, and the result of this is an inadequate force from the ventricles to produce blood throughout the body. So to define this, the EF must be less than 40%. So if you kind of look at these two numbers, the 40% and 50%, you can see that there's a gap there. Just remember the cutoff of 40% throughout this presentation. So if the EF is less than 40%, then the patient has a reduced ejection fraction heart failure. If it's greater than 40%, you can assume that they have a preserved EF. So if we look at the differences between systolic and diastolic heart failure compared to the normal heart, you see with systolic heart failure we have a really big ventricle here, and whenever I was learning in school, I was taught that this is kind of like a plastic bag. If you fill up a plastic bag with fluid and try to pump it out, you're not going to be able to get all the fluid out. So these are patients that have a reduced EF. And then for diastolic heart failure, you can see that it's much more narrow, very fatty sometimes, and typically this is caused by patients that have hypertension. But with this type of heart failure, you still have a preserved ejection fraction. Here are the signs and symptoms of heart failure. They're really classified into two categories, and I won't sit here and read through all of these, but you should always be assessing your patient's volume status, and if they do have an increase in volume, either by noticing a cough or rales or potentially edema in their legs, then the treatment of choice is diuretics. And then if a patient has signs or symptoms of hypoperfusion, then the treatment of choice is inotrops here, and they'll need to be admitted into the hospital for that. So jumping into therapeutic management, first and foremost, we should always focus on non-pharmacologic therapy. And these are very specific to heart failure, and I would note these to memory. The two that I've underlined are probably the two most important that you'll want to write down. So you'll want to restrict their diet to less than 200 milligrams of sodium a day, as well as limit their fluid intake to less than 2 liters per day. And this is any patient with heart failure, whether it's preserved ejection fraction or reduced ejection fraction. As well as we want to encourage exercise and eliminating other modifiable risk factors as well. Jumping into the medication, it's very important to initially differentiate what type of heart failure they have. So do they have preserved EF or do they have reduced EF? It's important to differentiate between the two of these because some of our medications specifically decrease mortality in our patients with reduced ejection fraction heart failure. And so if at all possible, you want to make sure that your patients are on these medications. For our patients that have preserved ejection fraction, there's really only one medication that has promising data, and otherwise it's really important to pay attention to the non-pharmacological treatment options. So to specifically talk about heart failure with reduced ejection, remember, reduced ejection fraction is defined as an EF of less than 40%, and I would commit this slide to memory. So the medication classes that I've highlighted in green are the medications that have been shown to decrease mortality, and so therefore we really want to make sure that our patients are on these medications if they can tolerate them. And then I've also highlighted in green with the hydralazine nitrate combo. that this has also been shown to decrease mortality in patients with heart failure, but only in our African American population. So this is added on after the other medications, specifically in our African Americans, if they can tolerate it. Talk a little bit about each of these classes. So first, with our ACE inhibitors, again, it should be added in all of our patients with heart failure with an EF of less than 40%. I put a little blue box around the three that you'll probably see most often: captopril and allopril and lisinopril. And whenever patients are taking these medications, we want to be aware of some of the side effects, specifically the cough. So cough is prevalent in about 15 to 20% of patients that take ACE inhibitors. And if a patient does experience a cough, there is an alternative agent, an ARB, that they can use instead. Angioedema is also a really important one to keep in mind, swelling of the lips. This can be life-threatening. And so if your patient experiences anything like that, you'll want to refer them to the hospital. And then as well as hyperkalemia and monitoring the serum creatinine. So ARBs are recommended in all patients with reduced EF less than 40% who are intolerant to ACE inhibitors. The cross-reactivity of angioedema, if a patient has angioedema on an ACE inhibitor, is about 2.5%. So if a patient does have angioedema on an ACE inhibitor, it's reasonable to consider switching them to an ARB. And then here are the three most common ARBs that you'll see in clinic.
The next class of medications are beta blockers. So these medications are recommended for all symptomatic or asymptomatic patients who have an ejection fraction of 40% or less. The three beta blockers that are currently indicated and have evidence for heart failure are bisoprolol, carvedilol, and metoprolol succinate. Of note, metoprolol tartrate does not have evidence of benefit in heart failure, so we only use succinate. The two biggest side effects that we'll see are bradycardia, since we're directly affecting our heart rate. You can also see hypotension. Of these three medications, carvedilol will have the highest risk of hypotension since it has some beta and alpha effect, which can be a positive or a negative effect depending on your specific patient. For beta blockers, you want to avoid any abrupt discontinuation. And another side effect that you can see with beta blockers is fluid retention. So any use of diuretics in patients with fluid retention, you just want to be careful with. If a patient comes in volume overloaded and you want to start them on a diuretic or increase their diuretic dose, I would recommend holding off on any further increases in their beta blocker or starting a beta blocker in general. We usually want to see patients euvolemic or at least have a stable volume status before starting or increasing a beta blocker. And then, of course, if you're starting this medication, I would recommend starting low and go slow, titrate up slowly. Another side effect that you can see is fatigue. Since the patient's heart rate is going down, their body gets more fatigued over the next few days because their body is getting used to a lower heart rate. So this side effect will usually go away after a few days or maybe a week or so. So we usually, when we either start or increase a beta blocker, we'll wait a month and let their body get used to their new lower heart rate before we make any further adjustments.
So one of the biggest takeaways from everything that I've covered so far is which agents to use in which patients. And really what we should do is use either an ACE inhibitor or an ARB in combination with a beta blocker in all patients with reduced ejection fraction heart failure. And then it's important to mention that Entresto can be substituted for an ACE inhibitor or an ARB. Now we'll jump into some of our more specialized agents. So the first ones I'm going to talk about are the aldosterone antagonists. that being spironolactone and eplerenone. Now, these agents should only be selected in our patients that have an EF of less than 35%, whereas the agents that I covered prior to this were recommended in a patient that has an EF of less than 40%. So you can see that there's just a smidge of a difference there. There's specific parameters in regards to who we can initiate these therapies in. So the creatinine, there is a cutoff as well as a potassium cutoff. And you can see that there's quite a bit of monitoring that goes into this. So you need a patient that's going to be fairly adherent to coming in to visits. And then there are side effects associated with these that either hyperkalemia, hypotension, you get an impact on the kidneys, and then gynecomastia is associated with spironolactone. The next class of agents are oral nitrates and hydralazine. And I just want to mention that really these agents should be used in combination, if at all possible, in our patients with heart failure. So Bidil is the drug of choice here. And Bidil should be initiated in all African American patients after they're already on an ACE inhibitor or an ARB or Entresto in combination with a beta blocker. And they're recommended in our African American patients because there's a study that came out that showed that they also offered a mortality benefit. And then something that I think is really important to mention is that we have a very big drug warning here with phosphodiesterase 5 inhibitors, so sildenafil or Viagra, tadalafil or Cialis, and vardenafil, in combination with any of the nitrates. So really they're contraindicated to be taken together. If your patients are adamant about continuing their phosphodiesterase inhibitor therapy, then it's important to mention that they cannot be taken within 24 hours of each other or 48 hours for tadalafil. And that's because of severe vasodilation and hypotension.
Our SGLT2 inhibitors are a newer class of medications that we're using in our heart failure population. These medications are typically were found to be beneficial in patients with diabetes initially, and that was what their initial indications were for. But when the FDA had released a statement that mandated that all diabetes medications had to go through cardiovascular testing, those trials had actually found that patients who were on SGLT2 inhibitors with diabetes had less heart failure hospitalizations. And so that kind of posed the question of, what would the population be if they didn't have diabetes and taking these medications? Would they still have that benefit? And so there were some studies that looked at SGLT2 inhibitors in half patients with diabetes, half patients without diabetes, and they found the same benefit. So patients who were on these medications had less heart failure hospitalizations and had some more of those cardiovascular benefits. And so therefore, Farxiga or dapagliflozin is our first and only SGLT2 inhibitor currently indicated for patients with HFrEF. There are still ongoing studies with empagliflozin that is showing promising data, and so empagliflozin can be considered to be added on to patients with heart failure if the insurance companies would prefer that over Farxiga for whatever reason. And so really the mechanism is more targeted to kind of reduce the amount of blood sugar in the body, and so it has a lot of effects on like the filtered glucose in the lumen, and then decreasing the renal threshold for glucose. But some of the theoretical heart failure benefits include like a possible diuretic effect and then metabolic effects. And so I just put on, for the sake of what was FDA indicated for now, is the dapagliflozin, the brand name Farxiga, and it's at 10 milligrams daily. That showed no difference between if it was the 10 milligrams versus the 25 milligrams of Farxiga in patients. And so really just starting out with kind of that lower dose, since we see the same benefit there. But however, if you do have a patient with heart failure and diabetes, it would be okay to start them off at a 25 milligram tablet. So just to recap some of the highlights of what we've talked about so far. So ACE inhibitors and beta blockers are standard of therapy for patients with HFrEF or an ejection fraction of less than 40%. An ARB can be substituted for an ACE inhibitor, and Entresto can be substituted for either an ACE inhibitor or ARB. This spironolactone or eplerenone can be used for patients with HFrEF if they have an ejection fraction of less than 35%. And then combination hydralazine and isosorbide dinitrate as well as aldosterone antagonists can be added to the standard therapy of the ACE inhibitor or beta blocker and select patients for additional morbidity and mortality benefits. Combination of ACE inhibitor and ARB is not recommended because there is a higher risk of hyperkalemia. And for patients who are started on SGLT2 inhibitors, we can be adding that Farxiga regardless of the diabetes status.
So now we'll jump into our agents that do not offer mortality benefit but may decrease hospitalizations or symptoms. So Digoxin is an agent that has been shown to decrease hospitalizations. Its mechanism of action is a positive inotrope, and it has pretty specific dosing and monitoring. So the dose really depends on some different patient factors. If they have poor renal function, if they're very small, or if they're over the age of 70, then we'll want to start lower. But really what's most important here is that we monitor the digoxin and we look at the threshold of 1. So we need to make sure that the digoxin levels all remain less than 1 for patients with heart failure, and this is really just to prevent any types of toxicity. It's also important to mention that digoxin may be used earlier on in patients with heart failure if they have underlying AFib, because there are some rate control mechanisms with the drug.
Another drug that I would like to mention, since we are seeing this a little more in heart failure management, is the medication ivabradine, which is also known as Corlinor. In the SHIFT trial, ivabradine was shown to reduce heart failure death or hospitalization. Its mechanism of action is to inhibit the F current, also known as the funny channel, in the SA node, and with that you have a reduction in heart rate. Where you would see this is in our symptomatic HFrEF patients with an ejection fraction of 35% or less who have undergone a hospitalization for a heart failure exacerbation in the previous year, and they have a resting heart rate of 70 or greater despite the fact that they are on maximum beta blocker dose. So as you can see, this is an add-on type of medication. The initial dosing schema would be 2.5 to 5 milligrams BID, and we would titrate the dose until we reach a heart rate of 50 to 60, titrating by about 2.5 milligrams at a time and capping that dose to 7.5 mg BID. This is not a medication that we would use in acute decompensated heart failure. It is actually contraindicated to do so. And it's also not a medication that we would use in our AFib patients, considering the mechanism of action.
Diuretics are also used in patients to prevent hospitalizations as well as control symptoms. And diuretics are used in patients that we're concerned about their volume status or if there's clinical evidence of fluid retention. Loop diuretics are diuretics of choice, especially over any of our thiazides. And it's important to mention that there's a lot of monitoring that goes in whenever we start patients on diuretics. We want to specifically monitor their potassium and magnesium as well as the renal function. And diuretics can also cause hypotension and some degree of renal dysfunction. So like I said, we'll be using loop diuretics in our patients with heart failure. The 3 loop diuretics are bumetanide, torsemide, and furosemide. And furosemide will by far be the diuretic that you see used most often, and that's primarily due to cost. I wanted to mention potassium replacement because in most patients that are on diuretics, they will have some degree of hypokalemia. And so just a rule of thumb, for every 10 milliequivalents of potassium chloride you give a patient, they'll have a 0.1 increase in serum potassium. And for every 20 milligrams of furosemide, you can consider 10 milliequivalents of potassium chloride to prevent that hypokalemia.
One other important thing to point out for patients with heart failure is the importance of IV iron and iron deficiency anemia. And so iron deficiency anemia is widely present in patients with heart failure, and that's defined as either a ferritin of less than 100 or a ferritin of 100 to 299 with a T-stat of less than 20%. There are some risk factors that make people at higher risk for having iron deficiency anemia, and that would be for female patients, for those with advanced heart failure for stage 3, 4, and for patients with a higher BNP or CRP. And so for patients who do have iron deficiency anemia, we should really be using IV iron as the preferred route for treatment in heart failure. And so IV iron can be used in some of our outpatient transfusion centers, so this doesn't require a hospital admission, but it's important to know that IV iron is the preferred route because there's no data that has shown efficacy of oral iron for iron deficiency anemia. And so we can use a number of some different iron products, but the ones that were studied more frequently were the iron sucrose and then the ferric carboxymaltose. And so with our treatment goals for this, we're hoping to improve the quality of life. There's decreased mortality and then decreased hospitalizations with replacing iron in patients who have iron deficiency anemia.
Briefly, I want to talk about heart failure with preserved ejection fraction. Now, it's important to mention that all of the slides that I've covered up to this point are really just about agents and the mortality benefit in patients that have reduced ejection fraction heart failure. So with our
HFpEF is when you have a preserved ejection fraction or an ejection fraction greater than 50%. And at this time, Entresto is the only medication that has an FDA approval for HFpEF. Now, this is based off of the Paragon HF trial, which found some benefit in reducing cardiovascular death and heart failure hospitalizations in the HFpEF patient population. In 2021, the Emperor Preserved trial came out that was studying empagliflozin or Jardiance in the HFpEF patient population. And this study found that there was a reduction in the composite endpoint of cardiovascular death and heart failure hospitalizations as well. But these results were mainly driven by a reduction in heart failure hospitalizations. Now, what we don't know is whether this is a class effect. So currently there is a trial looking at dapagliflozin or Farxiga in HFpEF, but those results aren't out yet. So it'll be interesting to see whether they see the same results and if that leads to an FDA approval. Now, exercise has definitely been shown to decrease the progression of HFpEF, so we definitely want to recommend that for our HFpEF patients. ARBs can also be considered to decrease the risk of hospitalizations based off of the CHARM Preserved trial. And spironolactone also has some data in HFpEF as well. And then, of course, we can recommend beta blockers in patients who have a prior MI, hypertension, and AFib requiring rate control. So HFpEF is definitely a hot topic where a lot of trials are coming out these days. It's been interesting to see an increase in the number of approvals and the number of drugs that we can use for this patient population.
Lastly, it's important to mention drugs that precipitate heart failure. The ones that I've highlighted in red should really be taken into account. So NSAIDs or COX-2 inhibitors should specifically be avoided in patients with heart failure, especially COX-2 inhibitors like celecoxib, because there is a cardiovascular risk associated with these agents. Diltiazem and verapamil are specifically contraindicated in patients that have reduced ejection fraction heart failure, so should be discontinued if a patient does have an EF of less than 40%. And then amphetamine should be discouraged in any patient that does have heart failure.